Thank you, Dr. Haile Jesus. Thank you, everyone, for having me today. Hope you're having a wonderful evening in Addis. I will share my screen. Okay, can you confirm that you can see my screen?
Yeah, it is visible.
Great. I may
Yeah, we
not be
can.
able to see your hand raised or questions in the chat, so if you have a question, you can feel free to ask it if something is unclear, and we'll have time at the end. So today we'll be talking about vasopressor use in the ICU, and I'll review why we need vasopressors, what they are, how they act, and how they work. And then we'll talk about which one to choose and review some papers that delve into different types of shock and the selection of which pressor you may want to use based on the clinical scenario. So, shock is a state of systemic hypoperfusion that's characterized by inadequate blood supply to the tissues. Typically, this manifests as hypotension with a MAP less than 65. We all remember that MAP is your diastolic blood pressure plus 1/3 of the pulse pressure. And when this is less than 65, usually the blood supply is inadequate to perfuse tissues. Can also manifest as an elevated shock index, which is your heart rate divided by your systolic blood pressure. And a shock index greater than 0.8 can represent significant instability. You'll also see evidence of end organ dysfunction that can manifest as oliguria, urine output less than 0.5 cc's per kilogram per hour, a prolonged capillary refill time greater than 5 seconds, modeling of the patient's skin. You see here on the right, there's this modeling score. And when the area of modeling extends far over the thigh and onto the lower leg, this can represent pretty severe hypoperfusion, as well as altered mental status or an elevated lactate. So there are many etiologies of shock, and we tend to group them into general categories, being hypovolemic, distributive, cardiogenic, and obstructive. And so whenever you're seeing a patient to evaluate them for shock, you want to think of these four categories. There are many specific etiologies of shock within the four categories, but some of them, more representative ones for distributive shock, may be sepsis or anaphylaxis. Hypovolemic shock can be hemorrhagic shock or fluid losses from other causes, including GI or abnormal renal pathology. Cardiogenic shock can result from arrhythmias, from heart failure exacerbation, myocardial infarction, valvular disease. An obstructive shock typically can result from a PE, pericardial tamponade, or severe asthma. So let's take a patient scenario. You're called to your patient's bedside. This is a 65-year-old woman who's been in the hospital 2 weeks after being a pedestrian struck and sustained a lateral compression pelvic fracture. She had an ORIF of the pelvis. When you see the patient, she's unresponsive, hypotensive with a blood pressure 70/50, a heart rate of 135, and a temperature of 38.2. So if anyone wants to unmute and speak, I will ask the group, in this situation, what would you do? How would anyone like to evaluate the patient? And are there any early interventions that you would propose?
Hello.
Hello.
Hi. So, for this particular patient, there could be a few explanations for the shock. She's been in the hospital for a while, so it could be septic shock, or she does have certain skeletal fractures, which may have hampered her mobility, so she might have a pulmonary embolism. But regardless, we could try giving her a fluid bolus. During that time, we could reassess her with the rush protocol, maybe, if we have an ultrasound available, so that we can at least try to identify the cause of the shock.
Excellent. Thank you, Dr. Jonathan. That is a great idea. So many times in critical care, our job is to rescue the patient from sort of an undifferentiated emergency. And what you've proposed, utilizing ultrasound to help with your diagnostics, and then empirically giving a fluid bolus are great ideas. This is sort of a general framework that you may use when going to the bedside to evaluate a patient in shock, making sure that you have IV access. You can send labs, maybe not all these labs are needed, but this is for a broad differential of shock, including cultures, get an EKG, an X-ray if you have that available. And then you may want to consider CT, either for pulmonary embolism or to look at the abdomen and pelvis based on the clinical scenario. The ultrasound is very helpful adjunct in these situations. You can quickly evaluate the biventricular function of the heart. You can assess volume status by looking at the IVC and potentially the VTI if you have the skills to look at the LV function. You can look for a pericardial effusion. You can also use your ultrasound to check for lung sliding and evaluate for possible pneumothorax, as well as looking for B lines to assess for potential cardiogenic edema. You can use your ultrasound to perform a FAST to look for intraperitoneal fluid. And I personally don't have the skills for this, but some people feel comfortable looking at the aorta to assess for a dissection flap. So there are many helpful functions that the ultrasound can serve for us at the bedside. Initially, when you're managing shock, you want to ensure that the patient is monitored appropriately. So placing them on telemetry, using a pulse oximeter, consider transfer to the ICU to make sure that they're in a safe location. And then giving an empiric bolus for volume resuscitation is usually appropriate for the patient with undifferentiated shock. Based on their scenario, you could use either IV fluids or blood, and an initial sort of appropriate bolus amount could be 30 cc's per kilogram. Other therapies that you might consider are empiric antibiotics or steroids for refractory shock. Of course, holding any medications that could cause hypotension. So things like sedation if they're already in the ICU, or antihypertensives if they're taking those on a scheduled basis. You can consider adjuncts like calcium and bicarbonate that can improve the acid-base status and the vascular contractility. And then, of course, the reason why we're having this talk is initiation of vasopressors. So I want to first differentiate vasopressors versus inotropes, although many of the medications that we'll discuss today have overlap of their functions. So vasopressors are medications that induce vasoconstriction, increasing systemic vascular resistance and mean arterial pressure. And inotropes are drugs that enhance cardiac contractility and improve cardiac output. These medications function on different receptors in the body. And so I'm sure you remember this from medical school, but we have our adrenergic receptors, which are alpha and beta, and then our dopamine and V1 and V2 receptors. So alpha 1 are found in vascular smooth muscle and the heart, beta 1 found in the heart, beta 2 in the airway and vascular smooth muscle, dopamine in the kidneys, in the vasculature, GI tract, and V1 in vascular smooth muscle and kidneys, and V2 in the kidneys. So vasopressors essentially mimic the activity of endogenous molecules that regulate heart rate, cardiac contractility, and blood pressure. And our body makes three major classes of vasopressors. We have our catecholamines, which work on alpha and beta receptors. We have vasopressin, or ADH, which acts on the V1 and V2 receptors. And then we have angiotensin 2. When we think about the medications that we can give that act as vasopressors, they can be grouped into three broad categories: inodilators, inopressors, and pure vasopressors. And then you've probably seen something like this chart before, but the various vasopressors we can use have different levels of activity on alpha, beta 1, beta 2, dopamine, and V1 receptors. So you can see here, for example, norepinephrine has strong alpha 1 and moderate beta 1. And through this, it increases your SVR, blood pressure, and cardiac output. Whereas epinephrine has stronger alpha 1, beta 1, and moderate beta 2, so increases heart rate, cardiac output, and SVR. We'll go into each of these drugs in more detail, but this chart can be a helpful one just to remind yourself of the different affinity to various receptors. So we'll start with inodilators, and we won't spend much time on these medications because they're not really pressors, but we should briefly discuss them so that you know sort of their function and their role. Inodilators increase cardiac contractility and actually cause vasodilation. So these are typically used in patients with cardiogenic shock to improve their cardiac function as well as reducing afterload. Dobutamine is the most common inodilator that we use, and it's both a beta 1 and beta 2 agonist. So it's going to improve your cardiac contractility and also cause peripheral vascular vasodilation. This medication can be arrhythmogenic, so that's something to keep in mind when initiating it. But this is the most common inodilator we would use for a patient with a heart failure exacerbation that needs volume removal. Milrinone has similar function, but it acts through being a phosphodiesterase inhibitor. And something to remember about milrinone is that it's renally cleared. So if your patient has renal dysfunction, the medication can accumulate and have toxic side effects. And then isoproterenol is also a beta 1 and beta 2 agonist. It's rarely used because it is very expensive, but it functions in much the same way as dobutamine. And so all these medications will improve contractility and reduce afterload. Those are the inodilators. Now, inopressors are pretty much the workhorse of our vasopressors that we will be using on a day-to-day basis. The inopressors work by increasing stroke volume, cardiac output, and increasing systemic vascular resistance. So you'll get improved cardiac contractility as well as improved blood pressure. The three main medications that we can use as inopressors are norepinephrine, epinephrine, and dopamine. And we'll go into more detail on each one of these. So norepinephrine, which is commonly called Levophed, that's the brand name, at least here in the United States, is a strong alpha 1 and beta 1 agonist. This is our first-line pressor for septic shock and can be used in pretty much any kind of undifferentiated shock and is often used as first line in cardiogenic shock as well. One thing to keep in mind is it can exacerbate tachyarrhythmias, though not as much as other pressors. So norepinephrine is going to be usually your go-to first line pressor for any situation. Epinephrine acts on the beta 1 as well as alpha 1 and beta 2 receptors. At lower doses, it has more beta 1 agonist activity. So at low doses, it can improve cardiac contractility more than acting as a vasopressor. And with higher doses, you'll see more alpha 1 activity, so more effects on blood pressure at the mid to higher doses of epinephrine. This is also used in septic shock, cardiogenic shock, and for patients with an asthma exacerbation can also have a bronchodilation effect. It can exacerbate tachyarrhythmias as well, and more so than norepinephrine. And then a very important thing to remember about epinephrine is that it causes elevated lactate that is not related to tissue hyperperfusion, but rather via a beta 2 receptor effect on the liver. And so if you're monitoring lactate as an endpoint of resuscitation or a parameter for looking at tissue hypoperfusion, the use of epinephrine can confound this lactate level and cause it to be falsely elevated. The third inopressor that we'll talk about is dopamine. And at least from what I recall in the clinical care in Ethiopia, this medication may still be widely used. In the United States, we rarely use dopamine, and that's because of its many side effects. But dopamine has various impacts on cardiac output, heart rate, and SVR, depending on which dose is used. So low doses, you'll see mostly dopamine receptor activity with a small increase in cardiac output and decrease in SVR. So at low doses, it can actually lower blood pressure. At medium doses, you'll see more beta 1 activity, and with that, increase in heart rate and cardiac output. And then at higher doses, you'll see the most alpha 1 activity, so an increase in SVR. This dopamine has been shown in multiple studies to be inferior to norepinephrine and epinephrine for cardiogenic and septic shock. And so because of this demonstrated inferiority to the other inopressors for various types of shock, as well as its side effects being very arrhythmogenic, difficult to titrate, and with a high risk of tissue necrosis if it extravasates, we rarely use dopamine in ICUs today. The third category that we'll discuss is pure vasopressors. So pure vasopressors increase the SVR alone, causing an increase in systolic blood pressure in preload and in afterload. And so the three pure vasopressors we will talk about today are phenylephrine with the brand name neosynephrine, some people call it Neo, vasopressin, and angiotensin II. Phenylephrine is a pure alpha 1 agonist. So this acts just on the peripheral vasculature to increase SVR, and through that mechanism will cause an increase in blood pressure in preload and afterload. This is most often used by our anesthesia colleagues in the OR to reverse medication or anesthesia-related hypotension. It also causes a reflexive bradycardia due to the peripheral vascular constriction. And so some use cases for phenylephrine in the ICU can be if a patient is having arrhythmias with norepinephrine or epinephrine, you want to potentially give phenylephrine a try. Also in patients who have critical aortic stenosis, if they need additional afterload, um, and this would not be a good choice in patients with a low ejection fraction. We will also sometimes use phenylephrine if a patient has neurogenic shock that we know to be resultant from a spinal cord injury, because this can just restore that normal vascular tone. Vasopressin is the second pure vasopressor that we'll talk about. This is also equivalent to ADH, and it works on the V1 and V2 receptors that are found in the peripheral vasculature and in the kidney. Vasopressin should pretty much never be a first-line agent, but it is a good second-line agent to add if a second pressor is needed. It can also lower pulmonary arterial pressures. So in patients who have pulmonary hypertension, it can be a good pressor to add. And in patients who have a traumatic brain injury or cerebral edema and may be suffering from central diabetes insipidus, it can correct the hypotension and hypernatremia associated with this. It's also a great pressor to use for patients with hepatorenal syndrome, as it reverses the renal vasoconstriction from the nitrogen oxide species that are found in cirrhosis. And a potential adverse side effect of vasopressin is that this also has a high risk of tissue necrosis and digital ischemia if it extravasates. So vasopressin should never be given through a peripheral IV. The third pure vasopressor to talk about is angiotensin II. And this is a fairly new medication that was just approved for use in the United States. We actually don't give this at my hospital, and I've never given this. But angiotensin II acts on AT2 receptors, and by that mechanism increases SVR in the peripheral vasculature and in the kidney. It, in studies, has been shown to be of benefit if the renin levels are elevated greater than 200, or for patients who are previously on ACE inhibitors or have renal dysfunction on CRRT in sepsis. It does have some adverse side effects, such as increasing the risk of venous thromboembolic disease, and can also increase IL-6 production and the risk of multi-organ system dysfunction. So this is potentially a helpful adjunct, but only in specific patients, and it's not widely available. Finally, we can talk about methylene blue, which also acts as a pure vasopressor. But this is often given in sort of the end stage refractory shock when we're looking for something to give us a little more time with salvage of a patient while awaiting source control or activity of antibiotics or other therapeutics. Methylene blue inhibits nitric oxide synthase to downregulate cyclic GMP and increase calcium binding. And through this mechanism, it causes vasoconstriction. It's very effective for refractory shock of any etiology. And we can start by giving a test dose and observing for response. So you would give 2 milligrams per kilogram once and then see if the patient responds. If they are a responder, you could consider a methylene blue infusion, titrating that to MAP goal for 48 hours. However, there are numerous side effects of methylene blue. And I will say in practice, we're usually just giving bolus doses of methylene blue, and I don't have much experience starting patients on a drip for this because you're usually pretty far down their resuscitation by the time you're reaching for methylene blue. But it can cause pulmonary vasoconstriction because it causes vasoconstriction all over the body. And so this resultant pulmonary hypertension can cause RV strain. It also will alter the ability of your pulse ox to detect the appropriate SpO2, and so your pulse oximeter can give inaccurate measurements when using methylene blue. And then it can cause serotonin syndrome and it can cause hemolytic anemia in patients with G6PD deficiency. And then finally, we can give a medication called midodrine if we're trying to convert somebody to basically PO vasopressors. So midodrine is the equivalent to oral phenylephrine. It's a medication in pill form that is a pure alpha-1 agonist. And sometimes we'll consider adding midodrine to facilitate weaning from prolonged low-dose vasopressors in the efforts to liberate a patient from the ICU. It's also commonly given in patients with hepatorenal syndrome, or sometimes you'll see patients on this just as a standing dose before dialysis. However, in some trials, including the Midas trial, it was not actually shown in studies to facilitate weaning vasopressors, but we do anecdotally commonly use this in the ICU. So just thinking back and reviewing all the medications we just discussed, this chart can sometimes be helpful to visualize the degree of vasoconstriction versus inotropy that each of these medicines offers. So you can see here phenylephrine, vasopressin, midodrine just causing pure vasoconstriction, whereas epinephrine is giving you both vasoconstriction and inotropy. And then something like isoproterenol is just going to give you inotropy alone. So thinking back to our clinical scenarios here, which pressor are we going to choose? We've just talked about 9 or 10 options. So which pressor are you going to reach for in your grab bag? There have been many randomized trials looking at different choice of pressor for various shock states. And so I just wanted to pull out a few key papers that you can reference when determining your pressor of choice for various types of shock. So this paper was published in 2018 in JACC and was a randomized control trial to look at epinephrine versus norepinephrine for cardiogenic shock after an acute MI. I think, typically we would have reached for epinephrine for the positive inotropy as well as vasoconstriction effects. However, in this study where they randomized 57 patients to receiving epinephrine or norepinephrine and saw their response to refractory shock, they actually saw a lower rate of refractory shock in the patients who received norepinephrine, 7% versus 37% in those receiving epinephrine. And they also showed higher rates of lactic acidosis, likely through the mechanism that we already discussed. And so this study was terminated early, and they concluded that essentially norepinephrine had a lower incidence of refractory shock with similar effects on the mean arterial pressure and cardiac index. So in a patient who's recovering from an acute MI and has cardiogenic shock, you can reach for norepinephrine as your first pressor of choice. Then when we come to septic shock, what should we be reaching for? This is a somewhat older paper, but the SOAP2 trial was a landmark paper that basically showed that norepinephrine should be the pressor of choice in septic shock. This was a multi-center randomized control trial of about 1,700 patients. They were randomized to either receiving dopamine or norepinephrine first line for septic shock, and they did not see a difference in mortality, but there were far more adverse events with dopamine, 24% versus 12%. And then the dopamine group also had higher mortality if they had concomitant cardiogenic shock. So overall, for sepsis, norepinephrine is the first line pressor of choice. Then the use of vasopressin for hemorrhagic shock is a relatively new practice, but I wanted to highlight this paper because for those of you who manage trauma, it can be helpful to have in your grab bag. So, utilizing a fixed dose vasopressin for 48 hours for patients with hemorrhagic shock was shown to lower the transfusion requirements. So, this was a single center randomized control trial of trauma patients who were in hemorrhagic shock, and they were randomized to getting a vasopressin bolus plus a drip for 48 hours versus a placebo. And patients who received this vasopressin infusion had about half the transfusion requirements. They did have similar mortality and overall complications. And so in our practice, in my hospital, we will often give a vasopressin infusion for the first 48 hours in an attempt to reduce the transfusion requirements that these patients have. And then finally, we'll talk about the Athos 3 trial, which was the trial that established angiotensin II as a treatment for vasodilatory shock. So this was a randomized control trial of 344 patients who had refractory vasodilatory shock, and they were randomized to receive angiotensin II or a placebo. And they were looking for an endpoint of a MAP increase of 10 points or a MAP greater than 75 without an increase in other vasopressors. And so 70% of the patients in the angiotensin group achieved this endpoint versus 23% in the control group. So it's very effective at increasing blood pressure in patients with refractory vasodilatory shock. And they did not show any significant difference in complications or mortality. So this drug, as I mentioned previously, was recently approved by the FDA and can be administered as a vasopressor for septic shock. However, we do see those complications such as VTE that are heightened in this patient population. So, what are the possible adverse effects of vasopressors? These are very effective medications, salvage for patients in any type of shock, and they're very critical medications that can be administered in the ICU, but they do come with various side effects. So one thing we'll discuss is extravasation, which can cause tissue necrosis and digital ischemia, elevated lactate, particularly in epinephrine, and then mesenteric ischemia. So what happens when your vasopressor extravasates? This is a feared complication of vasopressor use. And the mechanism of injury here is local ischemia of the tissues caused by the vasoconstriction of veins, capillaries, and the vasovasorum and altered tissue metabolism. So if a pressor extravasates into an extremity, it can cause tissue necrosis and ischemia to the point where patients may need amputation of digits or potentially the entire hand in the worst scenario. So an antidote to the adrenergic vasopressors is a medication called phentolamine. And the phentolamine can be injected subcutaneously across the area of extravasation, and this can be redosed if the patient remains symptomatic. And so this is a good antidote for norepinephrine, epinephrine, and phenylephrine, and then less so for dobutamine and dopamine. For methylene blue and vasopressin, the antidote would be topical nitroglycerin. And so a strip of nitroglycerin can be applied to the site of ischemia, and that can be redosed every 8 hours as necessary. This is not a very effective antidote, and so for that reason, we prefer not to give vasopressin or methylene blue through a peripheral line at all. And then other things that can be done if the vasopressor extravasates are elevating the extremity, applying warm compresses, And then terbutaline is also a second-line therapy that can be injected locally across symptomatic sites. What about mesenteric ischemia? So we do not have great data on the type of pressor and the dose of pressor that can cause mesenteric ischemia. But we do know that high dose and multiple vasopressor use can lead to non-occlusive mesenteric ischemia. It seems to be higher risk with vasopressin and angiotensin II, which physiologically makes sense because those pressors can cause splanchnic vasoconstriction. But there's no strict threshold for the amount of pressor that's associated with non-occlusive mesenteric ischemia. And in one paper that looked at global events of mesenteric ischemia associated with pressor use, it is a very rare event. So only 104 reported of 23 million patients that were reviewed. So this is rare, but it does happen. And in a patient who's been either with a prolonged downtime followed by high dose pressor use, or in a patient who's had prolonged three pressor shock, keeping a high index of suspicion for mesenteric ischemia is very important to keep in your mind. So, in your patient with need for vasopressors, do you need to line them up? Do you need a central and arterial line? So, maybe yes and no. Peripheral vasopressors can be safe for a limited time. So, particularly giving norepinephrine or potentially epinephrine can be safe for a limited time through a PIV. You want to be able to monitor that IV for extravasation. So it should not be a deep IV that was placed with an ultrasound. Ideally, you want to have an upper extremity IV that is visible, that can be monitored for extravasation by nursing staff if that does happen. Ideally, not in the hand. And you want to make sure that you have phentolamine available at your hospital in case that IV does extravasate so that you have a reversal agent. Do not give vasopressin, do not give dopamine through a peripheral IV. The risk of tissue ischemia and necrosis is higher with those medications, and they don't have a good reversal agent. And then in general, our practice is to place a central line. If you're needing prolonged administration of pressors greater than a couple days or so, if you're escalating on pressor dose, so if your norepi requirements are greater than 10 or so, you may want to place a central line. And if you're starting a second pressor, you probably want a central line. And then similarly for arterial lines, if you can't reliably follow cuff pressures, or if you have escalating pressor requirements, are adding a second pressor, you probably want to place an arterial line for more close monitoring of that minute-to-minute blood pressure. So in summary, I just like this table here because I thought it was kind of funny. Norepinephrine is going to be your pressor of choice. It's the bee's knees. It's the best one. Epinephrine gives you more inotropy. Vasopressin, you're going to have a fixed dose, no titration. It's good as a second pressor. Phenylephrine can be good for tachyhearts because of the reflex bradycardia. Dopamine and dobutamine, low dose for stable bradycardia. Methylene blue, they say, all right, Dr. Smarty Pants, and angiotensin II, all right, Dr. Moneybags. Only if you have a well-resourced institution can you get the angiotensin II. So we can circle back to our patient now. The patient we discussed who had the pelvic fractures and you found hypotensive on the floor, as Dr. Jonathan mentioned, did get a fluid bolus, was intubated for poor mental status, and started on norepinephrine. She actually quickly escalated to max 3 pressor shock and was started on steroids as well for refractory septic shock, hydrocortisone and fludrocortisone. She ended up having urosepsis, and urine cultures grew Pseudomonas and Citrobacter. She quickly responded to antibiotics. Her hemodynamics improved, and she was extubated the following day. So, in summary, you want to start vasopressors for shock that's refractory to fluid resuscitation. Norepinephrine is a good first choice. You want to make your MAP goal greater than 65, and then tailor your choice of pressor to the clinical situation when you have more information, and consider a central line for prolonged or escalating pressor requirements. So I'll stop there. And thank you again for your time, and I'll see what questions you have.
Thank you, Dr. Starr, for this nice presentation and from the